Hello, hello, hello. Can you guys hear me okay? Is this working? Okay. Hello. Well, I think let's get started just so we have time. Thanks for coming. My name is Dan Fulton. I'm an infection doctor. And we wanted to have an opportunity to just share what's been going on with coronavirus. People are obviously hearing a lot about it in the news, quite a few updates coming out regularly. And last week sometime I read a report that I didn't like reading it, and it was that staff just felt like they weren't getting the information they thought they needed or having the opportunity to hear and ask questions and share perspectives. And so what I thought we would do today is talk about coronavirus in general, review kind of what the current state is at Mary Greeley and McFarland Clinic, and then talk about some anticipated states that we may see, and then try to leave plenty of time for discussion as we go forward. So if you do have questions along the way, that's also great. So let's talk for a minute about coronaviruses in general. Why coronavirus? Why now? Well, it turns out that there's a lot of coronaviruses in the world, and they infect both humans and animals. And so there's now 7 human coronaviruses, but there's all sorts of other, cat and dog and snake and other types of coronaviruses. So what can happen is if there's humans right very close with animals, and if a human has a coronavirus and an animal has a coronavirus at the same time, even if they're different, there may be some unique mutation and remixing of those things that then sort of creates something new, and that's why we see new coronaviruses popping up from time to time. We already have 4 coronaviruses that circulate all the time in our community. We've known about them since the late 1960s and early 1970s. They generally cause common cold virus. Sometimes they cause some pneumonia. Very rarely people get very sick from them. But in general, they're pretty mild. Part of the reason we know that is in the 70s, we infected a bunch of college kids with them on purpose to see what happened. They all did fine. So these are around, and our immune systems are used to dealing with coronaviruses. So then we have these new coronaviruses that have popped up over the past 20 years. So SARS was one that came out in 2002 from East Asia, kind of a similar remixing, and this caused about 8,000 cases worldwide, had about a 10% death rate. In the Western Hemisphere, Canada and Toronto had probably the worst of it. Then it kind of faded away. It just went away. We haven't seen a case in over 15 years in the Western Hemisphere. Then in 2012, there was this Middle Eastern version that we think came from camels, and some remixing there. That one had about a 30% death rate and didn't have as many total cases. There may have been other cases that weren't reported, but again, that one has dramatically faded away too. It's just not active. And now we have our current coronavirus, and this one is thought to come from a snake. So kind of the snake virus, interesting. So these are numbers from Monday night. They are obsolete. We're over 100,000 cases total now. But one thing I wanted you to notice has something to do with the way viruses spread. And a virus that has a high mortality rate, like this MERS-CoV here, when people die right away, they don't spread the virus very well. It's kind of like Ebola. When people die right away, there's not time for the virus to move around. So viruses that have a very high mortality rate often don't spread very well, as opposed to viruses like the common cold that don't kill anybody, but the little kids share those viruses for weeks and weeks. They spread everywhere because they have that capability. So one unique thing about this coronavirus is that although it is more severe than our common cold viruses, it is not as severe, we don't think, as SARS or MERS was. And what that is doing is creating a scenario where it actually does seem to have the capability to really move about. So that's a big bummer. On the other hand, it's not as severe as SARS or MERS were, so that's a positive. This is something else that's interesting. This just came out yesterday. They broke it up by kind of 10-day intervals. This is in China. And what they're showing here is the mortality rate. And so when this first was discovered, the mortality rate was being reported at 14 to 18%. And then if you look over the past several weeks, the mortality rate of people diagnosed in China with coronavirus has dropped dramatically. So we're not looking at a 15% mortality, we're looking at a 1%, which again, it's still 1%, but it's dramatically lower. And there's a few theories why this is happening. One is testing is becoming broader, so we're testing a wider range of people. There's always a bias towards testing sicker people first with a new thing, so it always looks worse than it is at first. Also, we're probably getting better at supporting these people. You know, China's had a great experience of how to take care of people with coronavirus, and they're probably just doing a better job of it over time. And the third thing is that viruses naturally evolve, and they evolve quickly. Viruses mutate. And so if we have a population of 100 viruses, and some of them, you know, they're all just very slightly different, but some of them are more likely to kill people right away, and some of them are more likely to act like the common cold. The ones that are acting like the common cold are the ones that are going to spread. And the ones that have very high mortality rate are the ones that are going to select out of the population. So most viruses actually mutate towards being less mortal over time. So this was the data from Monday night. This is the data now. So I don't have numbers, but countries all over the world are reporting cases. There's over 100,000 cases. A lot of the countries, it's one or two, but these countries highlighted here are still the ones that are on the CDC travel advisory, so level 2 or level 3 travel risk. That hasn't changed. But there are cases all over the world. In the United States, this was our data from Monday night. So this is the data from today that's just got case numbers for you here. So we're over, I think we're at about 150 cases total. A few things to point out here. There are no cases in Iowa. The cases in Nebraska, these were people that were in the biocontainment unit, so they were actually brought in as part of a travel screening process. They were actually ill and came to a place where they could be in appropriate isolation. Most of the community outbreak that we're seeing right now is in Washington and Kirkland, but there's cases popping up in the community in California, in New York, Florida, and I think it's just a matter of time before we have cases popping up in Iowa. They did some genetic analysis of the virus in Washington. I couldn't tell you how they do this, but they were able to estimate that it had probably been around in Washington for about 6 weeks already. So it may have been already kind of in the community, moving around. So what does coronavirus look like? Well, how do people look? And it looks like influenza. You know, so if people are coming into your clinic and they're complaining of an influenza-like illness, which a lot of people are right now, because we have a lot of influenza right now, that's what coronavirus looks like. So that's created, obviously, a big challenge for figuring out who's at risk. Most patients have a fever. Most of them have a cough. And then kind of a smattering of all those other influenza-like symptoms. Feeling sick, muscle aches, headaches, body aches. It's not really a diarrhea illness, generally. It's more a fever and a cough illness. So of the people that ended up getting really sick, like going in the intensive care unit, 60% of them had some other health condition that put them at high risk, like diabetes or COPD. That means 40% didn't. So people that otherwise are not ill can get pretty sick from this, at least from those initial days in China. One interesting thing is that it seems like kids are handling this really well. So only 1% of the people testing positive for this are kids. They must be getting it. I think they're probably just not getting very sick. Maybe people are used to their kids having runny noses, and then you just put up with it, or maybe you don't bring them in because you don't want to expose them. But it does seem like, in terms of the data we have, this is not making children very ill. That's good news. Maybe bad news is that I had heard some theories that people in China weren't doing as well because so many folks smoked in Wuhan, and it turns out that their smoking rates there weren't, in this study at least, aren't that different than Iowa. So our rate is around 20%. Although Story County's a lot better. I think we're at 10 to 15. So good job, you guys. Right. I think another thing is that in China, as I said, the virus is changing. It's becoming less severe. So even in this big study, less than 1% of people actually ended up dying from it. So in some ways that's reassuring, but we still need to be proactive. In terms of what does this look like if we take pictures of it, most people have abnormal chest x-rays, but not all. CT scan seems to be better, more sensitive. It's usually bilateral. It's usually kind of patchy, like what we would think a viral illness would look like. So we had somebody come in that we tested Wednesday, and their x-ray showed a bilateral pneumonia, and their CAT scan said this looks like a viral pneumonitis, and their influenza was negative. So we tested them, and they were negative. So people, this looks like what a virus would look like. It's not special. Labs, this is all really small. What I wanted to point out to you was a few things. First off, the white blood cell count is generally normal. People, about 30% had low platelets, which would be typical of viral illnesses. And then this study here about this test called a procalcitonin, this is a test we use during influenza season to help us figure out, does somebody have a bacterial pneumonia or a viral pneumonia? Because it turns positive if they have a bacterial pneumonia. So in this case, that held true for coronavirus generally, that people had low procalcitonin. So for the clinicians out there, procalcitonin might be helpful if you're trying to figure out, does my patient have a bacterial pneumonia, or is this more of a coronavirus, just like we would do for influenza. Otherwise, I found all of the general tests pretty non-specific. Just looks like a viral illness. So what is our treatment approach for people that get coronavirus? Well, there's no specific treatment. So treatment is what we call supportive. So first step is doing what we can to prevent it from being contagious. So that involves appropriate protective equipment, which we'll talk about. And then patients with infections often get dehydrated, so they'll need fluids. They'll probably need oxygen if they're in the hospital. They may need bronchodilators or nebs if they've got some underlying COPD. They can get Tylenol to help their fevers, make them more comfortable, although fevers generally don't hurt people when they have them, but they're not comfortable either. And then you watch for complications of being ill. So a secondary bacterial pneumonia, which is something we see commonly with influenza. I imagine we could see that with coronavirus too. And then obviously if somebody's very ill in the intensive care unit, there's all the potential complications of lines and tubes and Foleys and all those things that are just part of being really sick. So we do have advanced measures if people do have more trouble with their lungs, like mechanical ventilation. And then there are these potential options for treatment, which I would say are really our potential in the sense that we will give steroids to somebody that has really bad influenza if we're kind of out of things to try, because we're just trying to shut the inflammation process down and buy some time for them to heal. So that's something we may do. Ribavirin is an antiviral medicine that kind of boosts the natural human antiviral immune process. I've given it several times for people with coronaviruses who were bone marrow transplant patients who had no immune system to help them out. It's really never worked in that population. It's not recommended for coronavirus in general, except kind of if you're out of other options. It might be something we'd consider if we did have somebody that was really, we were out of options for things to try. With viral illnesses, we sometimes will give something called IVIG, which is pooled antibodies from the community. The challenge with that is it assumes that the community has some immunity to whatever virus you're trying to help your patient with. And in this case, at least as of now, the community doesn't have any natural immunity to this virus. So that may not be that helpful. And then there's some experimental drugs that you may have read about or learned about. Protease inhibitors are something that we've used for HIV for 30 years. Coronavirus does have a protease gene, and so there's been theories that maybe these would help people. I think what's going to limit us there is people don't show up until the virus has already spread in their system and their immune system is responding. That's what makes people sick, is the immune system. So by the time they actually show up to talk to you about being ill, the cat's kind of already out of the bag, and I'm not sure this drug is actually going to help. People have wondered about, could we use this drug for prevention if I had an exposure? It's an interesting theory. I think they're looking into that. It does tend to cause a lot of diarrhea, and they're really not cheap. So in terms of who's going to be paying for this for prevention for millions and millions of people, I think that's pretty unlikely unless there's hard data to support it. So I don't look for protease inhibitors to be the magic bullet here, even though you may read about them on the news. And I guess the last thing is vaccine development is underway. Even if we had infinite resources to develop vaccines, there are just simple, practical, time-related things that you can't speed up. You have to find a population at risk. You have to give them a vaccine that you think is safe. Then you have to give it time to find out, did it work or not? We won't have a vaccine this year, period. I just don't think that's a reality. So how does this thing move around? It's just like other viral illnesses. It's a respiratory illness, so it's in droplets. So there is a distinction that we should talk about between what we call droplets and airborne transmission. So this guy, as he's sneezing, you can see these bigger droplets here. These are gravity dependent. So when we talk about droplet transmission, droplets fall to the ground within 4 or 5 feet. So when we talk about wearing, a droplet mask, the idea is there you're preventing somebody from sneezing into your mouth, but if they sneeze over there, it's not like it's going to float around and then come in the sides. As opposed to airborne transmission, which is very small particles, which are capable of sort of floating around over space. So coronaviruses, in general, the 4 that circulate in the community, are droplet. They are in the bigger droplets, they fall to the ground, and we use droplet precautions, a mask and hand washing, and that's generally sufficient. With the newer coronaviruses, there have been a few episodes of what are called super spreaders. So one person on a plane is able to give it to the whole plane, probably because they're like this guy. They're just like spewing it everywhere, and it is floating around. But in general, we think that this new coronavirus is going to be a droplet virus. And actually, the WHO, the World Health Organization, is recommending we approach it like a droplet virus. That's different than what we're doing. We're approaching it like an airborne virus for now until we get more information. But it may be over time that the people that study this stuff determine that droplet isolation is more than sufficient for prevention, which would help enormously in terms of how do we approach patients that might be sick. Droplets can land on surfaces, so that's where the hand washing and the don't touch your face idea come into play. It's not thought that they live on surfaces for very long, though. So how long is very long? I don't know, a couple hours at the most, but it's not like you're gonna touch a doorknob that somebody touched 6 hours ago and pick up this virus. Plus, you're gonna wash your hands regularly anyway, right? So they have found viral particles in stool. Nobody knows if those are actually infectious or not. They think they probably aren't. They think they're just dead virus genetics that aren't really contagious. I probably wouldn't test that theory if I were you, but all the same, this is a respiratory virus. You guys are used to respiratory viruses. We see these all year, every year. Think of it like influenza. So what can we do? So because we're approaching it right now as an airborne infection, that means that we need to use N95 masks, which are generally fit tested to the particular person's face, or the capper. So you guys have seen the cappers around. I brought the one that sits in the Infectious Disease Clinic. I see people with tuberculosis frequently, so that's also an airborne one. So we use these frequently in our clinics. So that's why it sits in my office. They're pretty slick. You know, you just plug it into the battery pack. There's a plastic front that you attach to it. One of the techs was telling me that don't forget to peel off the extra plastic bit or it's very cloudy and you'll feel like you can't see. Is Rick here? Anyway, give Rick a heart. Anyway, so it just goes on, and then you've got this piece of plastic that goes under your chin, and then a little bit of air blows out around your ears. But you can hear, and the patient can see you. You can see the patient. So because we don't see very many airborne diseases, in general, this is our approach. Also, there's a shortage of N95 masks. So starting about a month ago, we did increase our N95 fit testing in anticipation of having a higher need. I would say what we weren't anticipating is the run on N95 masks from the community, which has really shortened the supply available. So we do have N95 masks that we use for a variety of purposes in both organizations. We're fit testing people that are kind of on the front lines, although I should say that because of the shortages, we're really trying to stick with cappers as much as possible, especially when we're still dealing with just a few cases. I think if we start seeing a lot of cases, we'd have to reimagine what we do. And I should also say that in Washington, where they had a lot of cases all at once, they just switched over to the WHO approach, which was just treating it as a droplet disease because they just did not have the capacity to do airborne for everybody. So that depends on how much we end up seeing here. If we see 1 or 2 cases, we'll probably be sticking with airborne until they tell us otherwise. If we see a lot more, then we would be approaching it more as a droplet, depending on the scenario. We use contact precautions, not contract precautions, although you probably want to take contract precautions too in general. But it is contact precautions with the gowns and the gloves. And then people will be in the hospital in a negative airflow room. In the clinic, it depends on the air circulation of the clinic room. Kind of the average is a 2-hour turnaround time of a clinic room. So different clinics are picking, like, what room can we put to rest for 2 hours if we needed to. I've been doing this for years with my TB patients. You just don't use that room for a couple hours. And we try to see those folks at the end of the day as well. This is really important. If you're sick, stay home. And that's always been true. It's still true. I think you all are so dedicated to your work that you often come when you might be ill. And I just think, especially right now, it's important that if people have a fever and they're coughing and they're sick, it's just better to stay home. And I think you'll be hearing that from your administration and management folks that's something we really need to encourage. And the last thing, you're hearing this all over the news, is wash your hands. Soap and water are great. The alcohol stuff is great. Purell costs $40 on Amazon. It's amazing. So soap and water at home is just fine. So that's really how we prevent transmission. Report came out today in MMWR, which is a publication of the federal government, showing that it seemed like healthcare-associated infection was very low. The people that are catching this are in either close contact for long periods of time, like in homes, or like the nursing home outbreak in Washington. So they've tracked these different exposures, and people that were exposed somehow through a brief healthcare encounter, it seems like the transmission rate in that setting, even when the perfect protective gear wasn't used, the transmission rate was really low. So that may also affect how the CDC guides us about what we use going forward. So testing. So really important key fact, both the clinic and the hospital have all the stuff we need to do the testing. It's the nose swab and then a mouth swab in viral media. So when we do our limited biofire test in the clinic or hospital, that is actually the nose swab, and they can use that later, and then they swab the back of somebody's throat. This has been getting a lot of media attention, in part because it's a new disease, so the tests are limited. So, imagine if you have a limited amount of tests and you're trying to figure out how do we test whoever first. Well, you try to target the population at highest risk. So that's people that have traveled to countries with an outbreak, or people that have a known exposure to someone. Well, that assumes we know everything perfectly, and we just We don't. Things slip through the cracks. People are around that have been exposed. We don't know if they have been. And so that's probably where now the community spread has started. And so as of last Friday, they added this last category for testing about if somebody has a fever and they have severe respiratory symptoms like pneumonia, even if they have no exposure history, as long as you've ruled out influenza and you don't think they have something else, then that person should be tested for coronavirus. So that's a scenario. We've tested 2 people here this week. Both of them tested negative. I anticipate we'll have more that we need to test that fit into that category because, people have respiratory disease, they have COPD, they have an exacerbation, their influenza is negative, their procalcitonin is low, and for years we said, oh, it's probably a virus. And it probably was. Probably still is. But we need to know now if it's coronavirus. So we'll be doing that testing. And when I called the Iowa Department of Public Health, they were super friendly. They always are. And total time on the phone to get this all coordinated was no more than 15 minutes. So I told them the story, gave them the information. They called me back 10 minutes later. They faxed me a form. The nurse on the unit filled out the form, sent it with the test. A courier came to Mary Greeley, picked up the samples, brought them to the state hygienic lab, and we heard back the next day, patient's negative. The test takes about 4 hours. It looks to me like it's being run at 9 a.m. to 1. So even though it only takes 4 hours, why don't I get my answer sooner? They're probably just batching all these together once a day, is what I perceive as happening. So if we start getting more cases, then all of a sudden people will start meeting category number 2 there and qualify for testing. Iowa right now has 250 tests. So how long those last, they can ask for more from the CDC. And there's word that there will be commercial tests available soon. I don't know how soon. I don't know how well. This is technology that's been around, so I presume those tests will work. Once they become available, then we'll have to figure out how do we best work with our clinicians and public health to test the people at highest risk so that we're utilizing our resources well. I have a feeling that once the test is widely available, people will start to be widely tested though. And it'll just be interesting to see how that goes. I think the federal government has tried to say, well, if you want to have the test, you can have the test if your doctor says you need the test, and that's great. Where you'd get that if you didn't get it from Iowa Department of Public Health, I'm not sure. So right now, IDPH is using these criteria. They put this out yesterday. It's their same criteria I just showed you from last week. Travel to an affected area right now is any level 2 or level 3. So those countries I showed you. So Washington, California, there's 50 million people out there and we have 100 cases. So you're talking about, 1 in a million chance if you had traveled to those places of meeting somebody with, so the risk is incredibly low still on the coast, but that's something that may change over time. What do we mean when we talk about a close contact? Close would be within 6 feet for a certain amount of time, usually a couple minutes, and having not been wearing whatever the gear is that, we're recommending. So for now, that's airborne. There's a kind of complicated rubric about high, medium, and low contact exposures. So, if the patient had a mask on and I had my respirator on, but not a gown, that's actually a low risk one. If the patient didn't have a mask on and I had a gown but not the right mask, that might be a medium risk. And so all those things fit together in rubric because they help guide what was an exposure, particularly for our workers. And if somebody has a meaningful exposure right now, the guidance is that they would take 14 days at home on a furlough. That seems like a good approach when you have very few cases. I can tell you that in Washington, in the hospitals that are taking care of these folks, the people that had potential exposures very quickly ended up being 70 to 80% of their staff. You can't take care of people in that way. So they changed the way they approached it, and they said, even if you had a potential exposure, you still come to work, but you monitor your symptoms, and if you get sick, you have to stay home. So this is a moving target. We're trying to work with what we know about risk, what we know about ourselves, wanting to take care of our community members, and so for now, we'll follow guidance. If there gets to be a lot of cases and potential exposures over time, then we may have to modify or be flexible. a lot of those potential exposures happen when people aren't in perfectly airborne precautions, but were maybe in droplet. And so in that case, the risk would have been incredibly low anyway. So a lot of moving parts to these recommendations, but we do have that guidance, and we're planning to follow it, especially if we have a few cases that are trickling in. So the current state, at least at McFarland and Mary Greeley, and I put it this way on purpose because these two organizations have been working hand in hand on this issue for over a month since it started to come out. Both sets of teams have infection prevention teams that always meet, and this has obviously become their focus recently. We started travel screening about a month ago to initially China and then expanded it to other level 2 and level 3 countries, I think last week. We started increasing fit testing for what I just call frontline staff. Again, as we've seen more about shortages, that becomes less of a solution. Although I also think, people that are fit tested should be using those things. And then we've also been working with supply chains for over a month to try and make sure we have access. Now, the challenge is that we get a certain allotment of supplies from our suppliers. So we can't just say, well, we want extra. So then you try and be creative about going to other suppliers in other ways, but everybody else is doing that too, and the public is doing that too. So I would not be surprised if we see shortages, particularly of certain types of gowns, and potentially N95 masks if we tried to use more of them. If shortages happen, then we have to be creative and do what we can. And that's been true for both organizations as we've been preparing for all of this. So what do we anticipate? So we have to think about this very differently depending on clinic versus hospital, inpatient versus outpatient. So first, for the outpatients, most of the patients with coronavirus are going to be outpatients. So it's 90+% of people that get this don't need to be in the hospital, God willing. So then we have to have systems in place to be ready to appropriately isolate them as they're coming in. And then if there is a surge of patients, how do we take care of them? So right now, the clinic is following CDC and IDPH guidance for who to test. We are building phone triage stuff in the background. So if there's a lot of calls, that they wouldn't just be going to each individual clinic, but they would go to a centralized triage line that would help direct them. Do you go to your clinic, urgent care, the ER, depending on symptoms? Or if we're getting enough cases, we are anticipating we would use a centralized off-site location so that patients that were sick and could potentially be contagious are not walking in right next to the otherwise well person getting their knee replacement or the otherwise potentially ill person needing chemo. That all just depends on how many cases we end up having. So for now, those plans are being formulated in the background to be activated in the setting of having more cases, if we get them. McFarland right now is meeting weekly on Tuesdays, and we will be putting out a weekly Monday sort of update from Kelly, our infection prevention person, with updates from the state and county public health folks, and then me doing some editorializing about it. As far as MGMC goes, there is a weekly Friday meeting called Incident Command, which brings everybody together depending on the active issues. It's Leanne Hillier with infection prevention and Chris Perrin with the emergency team, and then everybody else you could imagine from lab and administration, nursing, OR. Because if somebody's in Mary Greeley, it's going to look very different. That person does have to be maintained in an isolated setting in a safe way for them and for their caregivers. So what that would look like practically is if somebody is suspected to have a case, they'll be in airborne isolation. We'll do the testing. If they test negative, then they come out. And just like any other illness, viral illness, we're taking care of them, supporting them, treating them as we go. If they do test positive, then they need to stay in airborne isolations while they remain in the hospital. If we end up switching to more of a droplet approach, they would still need airborne isolation for things like NEBS or intubation or kind of those aerosolizing procedures, just like we do with influenza right now. The patient doesn't have to stay in the hospital, though. If they get better, then when they're ready for discharge, they discharge home, and then they would follow kind of post kind of self-quarantine precautions just like anybody else. But I've gotten that question a few times. Do they have to stay in the hospital if they get better? No. As soon as they're ready to go, let's get them going. So right now, the plan is we will have patients be in respiratory isolation until we have more patients than we have respiratory isolation rooms, at which point we'll most likely use 3C as a ward of patients that have respiratory isolation needs. And then the question sort of becomes, well, who takes care of those people? So I'll be there. And I think the nurse managers are reaching out to their staff to see do people have special interest in volunteering. And, people volunteered for Ebola, people volunteered for H1N1. Remember, this isn't Ebola. This is a respiratory virus. This is influenza. We take care of that every day. So I don't think people should worry too much about this being something they do. I mean, this is why we went into this. So we take care of respiratory viruses every day. So this is my house. This is a painting that I have above the stairs that my wife Lois and the kids made years ago. Kind of started when the kids were really little, and we'd say, Clara, what's the first rule? Don't panic. What's the second rule? Be positive. What's the third rule? Kindness counts. So I thought, well, what if we applied these rules to what are we doing now? So I do think don't panic is a good place to start. This is a respiratory virus. You guys take care of these folks every day. It looks to me like the mortality rate associated with the virus is not going to be as high as initially we worried it would be. That doesn't mean it's not serious. That doesn't mean we don't take care. But you guys already do this work, and you'll be fine. I think being positive is kind of how do you be positive about a virus spreading? Well, think about it in the sense of, you know your job, you know where you work better than I know your job. And so you can positively affect the care of your patients by noticing, by paying attention, where are the gaps? How can we do better? What do I think is going to work better? And then stay positive in the fact that it may not always make sense. We don't always totally understand the guidance we're getting from public health. It changes from yesterday. I heard one thing, now I hear another thing. And I think the more we can stay positive about, we're all trying to do the best, and I assume the best about everybody that's trying to do this. I think if we focus on solutions and not just problems, we'll get a lot farther. And then kindness counts is, it could potentially be hard. And if it is hard, we're in it together. I just feel like we trust each other. We've been working together for years, and whatever happens, I think if we assume the best about each other, we'll get through it. It'll be fine. It's hard in a stressful situation to focus on kindness, and I think just remember that if people are stressed, that they'll come around and you'll come around and work together, and if we can focus on that and remember that, I think we'll come through just fine. And wash your hands, wear your gear, and stay home if you're sick. That's what you can do, and I think there's a lot of resources available. IDPH, Story County Public Health is going to be really helpful. Infection prevention committees for McFarland Board of Directors is kind of the highest up in terms of the chain of command and also their administration. Kelly is our infection prevention person and a member of a bigger committee that is going to be really helpful. And then the clinical managers and of course the physicians and APPs will be natural leaders here. And at Mary Greeley, it's going to be very similar. It's going to be public health. It's going to be the infection prevention committee. There's this incident command committee. Leanne Hillier is our infection prevention lead. And then administration, clinical managers, and then the physicians and other folks. So I think I was just in a meeting. We met with Iowa State this morning, and Chris Perrin made a comment about how if we think about Matt Campbell and focusing on the process, we're focusing on the process here too, because 5 years from now this could happen again, and I just feel really lucky to have been working with all of you, because I think it's really gone well. So So thank you all for your work. Thanks for your time. And we've got as long as you want to just talk about questions or things that you're seeing that you need answered or questions. Dr. Carlisle.
To me, it's not a question of if, it's when you get this first case and then you're going to have to deal with contacts, is that going to be, the contact's going to be done through a public health setting or I mean, when you start to look into the community after you get that sentinel case, I guess, as you envision, or what's the process?
That's a great question. I think it depends where in the process we are. So for the first case, I think Iowa Department of Public Health will be very involved. If we're the 50th case, I think they'll be busy. So I think it'll depend. I think the experience out of Washington was the more that we can do to pay attention to potential contact exposure, especially here in the workplace, that'll be our responsibility. Our public health or our infection prevention teams have those systems in place and have for years for TB and other things that we track. If there's a lot of cases, it'll be a lot of work. And we may need to pull other people in to be helpers in that setting. That's at least what they've had to do in Washington. People may have to be reassigned to different types of tasks to handle that when it happens, because I agree with you, I think it will. The better we can do with isolation up front, the fewer potential contacts we'll have. I think outside the hospital, outside the clinic, we are going to have to rely on public health to be doing the community contacts, right? But I think they're going to rely on us to do it kind of within this setting. Yes, Christy.
We're already kind of starting to see those MyChart messages roll in on patients asking, well, I'm immunocompromised, I'm on immunosuppressive, or I'm or whatever, asking what should I be doing in this situation. Are we going to be able to, or are you as a department going to create like a dot phrase or something that we could just blanket response so that everybody can have a consistent response to these people that are asking?
So the question was, as people are asking questions, is there some centralized messaging that we can give them? I think that's a great idea. If you wanted to make a dot phrase that seemed like it was working and share it, that would be great. But I mean, I think, especially for outpatients, one thing that we're looking at is for those patients of yours that are very stable and maybe don't need to be seen in the next couple months, maybe they're scheduled for just their yearly physical or a med refill, consider having them stay at home. Not right now, we have no cases in Iowa, but if we start to see more and more cases, if I was immunocompromised, the last place I would want to be, if I didn't need to be, would be in a healthcare setting. So working with your patients that may not need to come in, be helpful. Again, working with phone visits, be helpful. And then just focusing on all those other hygiene things. This is what you can do at home. Social distancing has come up time and time again. When and how and what does that look like? And there isn't a specific answer. From a system and a community standpoint, I think it'll really depend on when we start having cases. Where are those cases showing up? How many of them are there? How sick are people actually getting? Based on the experience of other places, the University of Washington just went all online today. I wouldn't be surprised if some big changes happen if we start seeing a lot of cases, especially for immunocompromised people. If we're seeing transmission in the community, I would say socially distance and avoid those big gatherings. I mean, my church is reaching out to me to find out what we should do at church, and church is social. That's the point. So, what reasonable precautions can you take that are pragmatic and thoughtful, make sense, but don't undermine the whole point? So. I'm not sure that was a great answer to your question. I like the idea of kind of dot phrases for people getting called frequently about how do we not be spending all of our time on documentation, but we actually can take these calls. But it may mean, too, for people that are mildly ill, that we say monitor. And if you get more ill, then call and come in. And we're trying to build that into the triage line It's going to be hard, though, because still influenza season. Influenza has a potential treatment. We're going to just treat people over the phone. Different clinics may want to handle that in different ways, so we'll have to work together. Yeah, not a perfect answer. Yes?
It seems like the Chinese and the South Koreans geared up for testing very quickly and have tested a lot more people than we have here in the United States. So I'm not trying to be critical of the CDC or the FDA, but do you understand why it's taken us so long to get these tests out to the public or out to?
Well, as of November 2019, this virus didn't exist. And so the amount of information that we have been able to learn in a very short amount of time is astounding. When SARS came out, it took years to sequence the thing. It took years to figure this out. So, the Chinese have been dealing with this since early December. We started hearing about what they were dealing with in January. They ramped up their testing through their centralized government system very quickly for that region where it was happening. I understand that there's been some difficulties with how the test was developed in the United States. I'm not sure the details but I guarantee you the CDC and federal government weren't trying to hold that process back.
The process was that
I think it's exactly like what if you have a limited resource and you're learning about something new and you have no cases in your country, then you focus on who's at highest risk. And then, we're seeing community spread. Now we really need to try and ramp up and be ready to treat. And so community spread started happening 8 days ago, and I'm hearing that there may be commercial tests available next week. I mean, it isn't perfect, but that's sort of the challenge of public health is this pragmatic, just-in-time approach. What if we had better public health infrastructure from the get-go? Would that help? Probably would have, but we are where we are, and I just think I think the testing is out there, and we now have tests in Iowa, and we still only have tested 8 people here, or 9 now. So I think the places that really need it are where the outbreak is happening. They're the ones saying, why don't we have more tests? And they have an argument there. Why aren't there more? Yes?
One of my nurses attended one of your sessions, and she came back with the understanding that the capper shields were a one-time use, but another nurse told me recently that it was per person. So could you clarify that, please?
Yes, and that's something that we've been trying to be flexible about as we've gone forward. In general, the capper face shield can be reused, especially in the outpatient setting where after use you can wipe it down with whatever the cleaner is that we wipe it down with. The challenge we ran into in the intensive care unit was so many people are seeing that one patient and they were all hanging their cappers end to end on top of each other. We just don't have the space to spread them all out so they stay clean and dry and all those things. So as far as the inpatient setting goes, for now we're saying one-time use. For the clinic setting, it sounds like since it'd just be your personal one that wouldn't be mashed with a bunch of others, you could probably clean it. And we'd have to ask Kelly what the cleaning stuff is, but that's my understanding where we're at right now. Dr. Mahaney.
Practical testing purpose in inpatient cases. Once we have a patient, we decide to test. What the process of testing, I assume if this gets busy, the expectation isn't that you're the only one who can talk to the public health. So
I hope not.
when we decide to test, is that something where the nurse can call Department of Public Health, get the necessary paperwork? Or does that have to be a physician phone call to Department of Health to get approval for testing?
That's a good question. I would probably have the physician or provider call at first because they did have some clinical questions about the patient. We've tested 2. I did the first one just so I knew how the process went. The second patient I didn't see, and I didn't do any of the testing. I did talk with the doctor that did it, and it went smooth and slick. So I think I'm available for questions and to be a resource as people encounter folks. And, depending on how ill they are, you may be seeing a lot of them too. But, basically the key is as soon as we think, okay, they fit that criteria of fever, they're ill with a respiratory illness, our other testing is nonspecific or we're not finding anything, hopefully we notice early in that process and get them into airborne precautions. And then that testing you do through public health. Does that answer your question? I don't feel like.
So the physician, it does. So the physician makes the initial phone call to essentially get permission to test from the Iowa Department of Public Health.
For now.
There, the paperwork can be done by.
Right. Yeah. When we did it, Amy did the paperwork in the unit. And I think when Dr. Steffel did it, the floor nurse did the paperwork. It's one form. It's not complicated. It's just like patient demographics and the address of your facility, basically. Each form right now is an individualized numbered form, though, so you can't just like save the form and photocopy it. You have to get a new form every time. And then public health sent a courier. They picked it up from the lab. I was stuck in a coronavirus meeting for mine, so I hadn't done the paperwork yet. So they actually picked up the stuff and sent it, and we faxed the form forward to the state hygienic lab. So public health has been wonderful. They're really helpful. They're in it to be helpful. So
Do you think there will ever be a setting where Mary Greeley or McFarland has their own testing on site?
yes, I think that's coming. It's like a race to the finish, I think. Our BioFire, our swab that we do right now, we already test for 4 coronaviruses. So if BioFire figures out how to add the DNA primers on for the 5th one, all of a sudden we're not doing anything different. Patient gets one test. It looks for influenza, it looks for everything else. And coronavirus positive, there you go, got the diagnosis, and we know what we do after that. Probably it'll be more of a standalone test at first, but I do think it'll be available to be ordered. But that'll then raise kind of interesting questions about, well, then how do we make sure that's getting reported to public health? How do we make sure the infection prevention teams are involved in isolation? So when that becomes available, there need to be some discussions about how that looks. Yes? Nope, behind you.
So in pediatric clinic on Saturday, I had a patient who traveled, her husband came in from travel outside of the country, and I was debating on whether she met the parameters for testing. And I questioned, and I couldn't find a clear answer. So what are this was before the 3rd box had been added.
Yeah.
So, and this is where I struggled, is like, what are the parameters for fever? So she's a child, and there's obviously different, fever for infant is different than fever for older children, and, it's subjective. So what are we seeing for, are they high fevers, low-grade fevers? What is subjective fever?
There have been studies that show that moms can tell if their kids are febrile as well as the thermometer. So if mom says they're febrile, they are. And I guess if...
Are they seeing, like, they're having high fevers, or are they...
Yep, fevers and cough and, it's variable, but those are the fever and cough folks, kids are the ones that you would wonder about. My discussion with public health, at least for now, that we have very few tests in Iowa, is that they would only recommend testing people who have severe lower respiratory infection, which would mean in the hospital. So then that gives you kind of a conundrum. Well, what if I'm at least marginally worried, there's community spread, and I need to wonder about coronavirus, but maybe the testing isn't available? I think right now the approach is you would approach it like any other viral illness. Kids should stay home while they have fevers and while they're coughing, and fevers need to be resolved off Tylenol. This is for adults too. Fevers need to be resolved off Tylenol, and the cough should be winding down before you would consider having them go back to their daycare, their school, or whatever. I think if we're actually seeing a lot of community spread, how long people stay home the guidelines will change. If you don't do the test, the recommendation is to approach them like other viral illnesses right now. We had a patient about 3 weeks ago from Western China come into the emergency department with fever and a cough. And at that time, China, Wuhan province or Wuhan city was the only place we could test people from. And so she did not qualify for testing. I would have tested her if I could have, but we weren't allowed to. They limited that because of the supply. And so we approached her as if she had it. We had her self-quarantine at home as much as we could. And then we talked with her, Nasreen, our nurse, talked with her every other day for 2 weeks until she was well. And then we said, okay, you're okay to, and even that was more than what public health was recommending at that time, but you have to just kind of take a pragmatic approach. But right now, if they're not very ill, I don't know that public health would test them. Mr. Dieter, do you have a question?
Yeah, question and then just hopefully a helpful reminder for the room. With regard to HIPAA, nothing about COVID-19 suspends HIPAA. And I think there's an abundance of curiosity that goes beyond necessary for treatment that we need to be very careful about throughout our healthcare environment. My question...
Can I share that comment just on the mic for the people? Mr. Dieter was saying that HIPAA still applies to people with coronavirus. That applies both to how we talk with our community members and also as care providers. If we're not involved, we don't need to be involved, just like usual. I think that'll be a challenge in the age of social media and family and all those things, but it shouldn't come from us, right? So, what was your question?
Then you mentioned that WHO is suggesting that it is airborne, or droplet, sorry.
Yeah.
Droplet. Is CDC unclear, or are they saying airborne today, or are they not saying?
So WHO right now is approaching this as a droplet contact precautions illness. WHO traditionally is working with areas that have lower resource availability. So whenever we make any sort of isolation guidelines, we are taking into account the infectiousness of the organism, the severity of the illness, the resources available. So WHO traditionally has taken a slightly lower need because of the resources thing. But data, I think, is coming out to say that that is probably going to be the right approach. For right now, the CDC is recommending airborne precautions. That's guidance, and we appreciate their guidance. And I think the experience out of Washington was, as soon as they had all sorts of infections, it just became completely impractical guidance, and they had to switch to a practical, pragmatic approach, which happens to also fit with the WHO guidelines. So for now, it's airborne. If that changes, you'll hear about it, because it would make everything a lot easier in terms of isolation if it was more of a droplet illness. And all 4 of our other coronaviruses are droplet illnesses. So you've been taking care of people with coronavirus for years, and you wear your mask, and you're fine. There was questions about what if I'm exposed at work? Do I go home? I'm going home. I want to sleep at home. I think self-monitoring is going to be the key, and common sense approaches within your family, depending on your family's risk factors, are going to be key. Hand washing and all the rest. I think if there was extenuating circumstances for people, I think there is potentially capacity for people to stay if they needed to. But remember, this is not Ebola. It's just not. It's a respiratory virus. You guys take care of these every day. So potential exposure, okay. Cough, fever. We all get 2.5 respiratory viruses per year. So you're used to this. You have an immune system, and it's designed to take care of you and experience new things as it comes. So I think we take it seriously, but remember, you do this every day. And thank you so much for your work, because couldn't do it without you. Thank you, thank you. All right, have a great day.